So let's talk about one of the newer options. We'll get to lutetium in a second, but metastasis, radiation metastasis-directed therapy. Have you integrated that into your patient management? When do you consider MDT? You know, what's the process there?
Yeah, definitely. I am a believer in focal radiation, especially in the low volume, in the pelvic nodes. I just sent the patient to, he had small volume recurrence in the retroperitoneum after having had initial pelvic radiation. And he's going to get radiated. You know, that's not standard, but we think that was the right patient. So I am a believer. I kind of unsure many times whether, you know, having, again, a patient with pelvic disease, low volume, whether radiation to the prostate, let's say that there's a small amount of 1 or 2 bone hits, you know. So that patient is already high risk, he has bone disease. So should we be radiating the prostate in the face of metastatic disease or not? And there's some data that supports that, you know. It's a conversation we have to have with the patient,
right.
You know, and you have to have a radiation oncologist who is, you know, follows along your philosophy. I think there's a place for that, you know. Again, not in the patient with disseminated disease.
It's interesting, you know, MDT, phase 2 data, I think we're all using it, you know, and that we found response rates where we can delay, you know, systemic therapies if possible.
Sure.
In your case where, you know, low volume disease, treat the primary, potentially treat the metastatic sites, they're definitely based on STAMPEDE data, there's an advantage there. Josh, how are you using MDT in your practice?
Very similar in the sense that if they, you know, they come in, they're considered a low risk, you know, metastatic patient. I try to counsel them that radiation to not only the metastatic lesions, but also to the prostate would be beneficial. The challenge is when they come in and they are a patient who is more of a high risk, they question why don't we treat the prostate, and we just really don't have the data to support the overall survival benefit of radiation to the primary tumor, at this time at least. However, there is some role, I believe, in especially painful bony mets, that in that patient, they qualify for at least an evaluation by the radiation oncologist. But by and large, in oligometastatic disease, we're finding more and more that stereotactic therapy has been shown to be beneficial, and I think that's, you know, we owe it to our patients to give them that option.
The other thing to jump in on that is, I mean, we've all seen those patients die of localized recurrent disease.
Right, yeah.
And it's terrible, bleeding and stents and all that stuff. So again, for that reason alone, I'm very aggressive. Like on those mCSPC patients, at a year, PSA is 0, Mets have basically gone away. I'm really aggressive in treating prostate and pelvis just because I think we're going to see some long-term benefit. I personally believe that, but at least they're not going to die of localized horrible disease, which is a terrible thing. Yeah. So I'm pretty aggressive on that in those guys that I think can tolerate it.
Yeah, it's very interesting how, you know, much has changed over the last decade.
Yeah.
How we chase lesions, we treat disease, we treat primary. You know, the mindset has completely 180. It's no longer, you know, just put them on hormones and see what happens. It's, you know, do advanced testing, find the lesions, treat the lesions,
right, and
put them on strong systemic therapy. With that in mind, let's talk a little bit about genetic testing. Josh has talked about his approach of an advanced disease. You get germline and somatic. Yeah. Rene, where are you with, you know, genetic testing? You know, have you integrated into your practice?
Everybody who is intermediate high risk gets germline testing from the get-go. If I have a more aggressive disease, I have maybe lymph node biopsies. I may consider that and do somatic testing as well. Patients who are positive for the known, you know, genetic mutations, you know, it'd be nice to be able to jump ahead of that with, you know, PARP inhibitor therapy early on. I think that I'm completely confident that's going to be the case. As soon as the data matures, why wait? Again, you just mentioned, you know, our whole approach has changed, being more aggressive even in the face of metastatic disease, and we know that early treatment, you know, helps patients live longer. So I think we're heading in that direction. But I do routinely test, and then of course if there's any evidence of PSA progression or radiographic progression, then get some either tissue or circulating cells genetics.
Ken,
Yes,
what's your
super
approach?
similar. I would say everybody with metastatic disease obviously needs to get tested. I think for a couple reasons, right? I think it's important, number one, for their families to identify risk for their family members, so that's critical. Again, like you said, there's going to be more and more new therapeutics out. We're going to be able to bring some of these things in earlier. So I think it's it's the future, and I think it's critical. I think the challenging part is, when do you retest sometimes? I mean, again, I think all of us here are really good at testing, and we have these patients who we've tested once. Maybe they've progressed on multiple different therapies, and now maybe it's time to test again for somatic. And we found a few of those people, but it's interesting to see how that changes over time. Yeah. Plus, I think we're going to identify, like you mentioned, some of the other kind of RB1 and things like that are out there. We'll find more and more and more of that to really find out who's going to do better on certain therapies. So it's all coming.
So we all believe in testing. We see the benefit. We see that we have therapies that make a difference. The reality is, most urologists and even oncologists aren't testing.
Right.
So what are the barriers? What are the challenges? Why do you think our partners across the country aren't doing testing?
Well, I think it's for the same reason that you mentioned earlier, that only 50% of mCSPC patients are getting multimodality therapy. I think, to use a very bad word, the dabbler word, which we always joke about nationally in these conferences, I think there's a lot of partners, not necessarily our partners, but doctors out there that dabble in advanced prostate cancer. I know none of you guys are doing advanced, female reconstruction for incontinence, right? That's not what we do. We love doing what we do. And I think in a group like ours, we really do inter-refer a lot. But I think there's a lot of dabblers out there, and there's a lot of people who just maybe don't see the benefit, or maybe they've tested a little bit and haven't found enough of those people with those defects, and they think, I tested 10 people, I'm not going to test anymore. So,
I think cost is also part of it.
Sure.
There are costly tests, and some insurance companies will, fight, and they will, require that you get on the phone with them, and they read all they do is they read what the guidelines say, and there's no argument with that. But I think that's getting better. I think there's a common realization that, like we said, this is going to be, or is almost already a chronic disease, and you have to keep testing.
So Josh, you, as the young guy, weren't trained in this in fellowship or residency. What were some of your challenges to adopting genetic and somatic testing?
It wasn't necessarily, like, the data was there. I knew needed to be done. It's the challenge is sometimes even getting the patient on board, because in their mind, it's just one more test that they have to undergo, that if you can really get them to buy into it, makes it much more of a conversation with them, that they'll want it and discuss it with their family. And when they buy into it, it makes it much easier to provide those services to them. Additionally, to Ken's point, where with somatic testing, trying to get a patient to understand the idea that the DNA or within the tissue itself may change over time. It can be a bit of a challenge to convey that to the patient, but it really provides an opportunity for newer treatments, or to give them a hope, even that despite their disease progression, we still are there fighting with them to give them other opportunities of treatment and that sort of thing. But to your original question, the biggest barrier really was just the layers of family and friends, and just trying to get everybody on board with the testing, I think, was the biggest challenge.